Good evening, everyone. How are you all? All right, everyone, let's start our tonight's session. We're going to start obstetrics today. I hope you finished or you are still studying gynae. Now, as we always say before we start the class, that anyone who join our sessions needs to make sure that you write your name in the Zoom so that we know who you are. Okay. So if we see that your name is showing as iPhone, iPad, something like that, we will not allow you to be in the class. And if we remove you, then you would not be able to join the session again. So please make sure when you join the classes that you write your name, because I can see two of the people's name is showing as iPad. You can rename yourself if you want, but you can't just keep it as iPad or iPhone. Okay. Okay, so for obstetrics, we will come to this video later on. So the chapters that we are going to go through for obstetrics is mainly from John Murtagh, and there are a few other things that we go through. Now, John Murtagh's 7th and 8th edition does not have enough topic related to obstetrics. 7th and 8th edition has only got these two chapters, antenatal care and postnatal care. So that's why we follow 6th edition, because 6th edition had these two chapters, chapter 109 and 110. So that's why sometimes we go through 6th edition for these two chapters, and then for the other two chapters we mainly follow the current edition. Okay. Then you should also go through the Gyneian obstetrics questions from the handbook. There is a book called Lillian Jones, which you can go through if you want, but it is actually not needed. You can also read Kaplan's Step to CK Obstetrics for some better idea. Solve the Q bank, solve the past questions, definitely. Okay. Obstetrics and gynae is easier in a sense that most of the questions are the similar type of questions, and the topics are quite similar. So if you know the important questions, if you know the important topics, then most of you will get more or less similar type of topic in the exam. Okay. So now we are going to start. So we'll mainly follow through the notes today. And if there is anything that we need to go through from JM, then I will let you know. So keep an eye on the notes at the moment, and we go from there. So the first topic that we are going to start today is high-risk pregnancy. So chapter 110. High-risk pregnancy is important, very, very important. It comes in exam a lot. So that will be our main focus for tonight. So first of all, advanced maternal age. So advanced maternal age means if a woman is above 35 years, they are at increased risk of fetal anomalies, especially chromosomal anomalies. And the most common chromosomal anomaly is trisomy 21, which is Down syndrome, and then trisomy 18. So advanced maternal age, that's definitely a high-risk pregnancy. You can see that as the age of a patient goes higher, the chance of Down syndrome also gets higher. So a woman who is 40-year-old has a risk of Down syndrome baby 1 in 63, okay, or 1 in 110. So the total risk is actually risk of having a chromosomal abnormality baby, and this is Down syndrome risk. So 1 in 110 risk, which is really high, right? 45, 1 in 32, 49, 1 in 12. And if you see that for a 25-year-old, the risk is pretty low. So sometimes they ask you these questions, that what is the risk of having a Down syndrome baby for a patient who is 35-year-old. So that's why you need to memorize at least these three, 35, 40, and 45. So aneuploidy, is mainly what we call about chromosomal abnormalities in a child. So chromosomal abnormalities is not our topic to discuss. Just remember the most common trisomy, or you can say the most common chromosomal disorder in first trimester miscarriages is trisomy 16. And the most common trisomy at term is trisomy 21 or Down syndrome. So these are the important things. So they can always ask you that what is the most common chromosomal abnormalities in a child? So at term, it means when child usually are born, at term the most common trisomy is trisomy 21. And if they ask what is the most common trisomy for first trimester pregnancy loss, that will be trisomy 16. So what is the high risk pregnancy cases? High risk, definitely elderly primary gravida, means that if the first time pregnancy is in a patient who is above 35. Grand multigravida, so if someone has got 5 or more pregnancy, that's grand multigravida. Prior poor obstetric history, someone who had complicated labor, they are always a high risk. Previous C-section, hypertension, obesity, short stature, diabetes. So all of these are high-risk pregnancy patients. So first of all, we are going to discuss about hypertensive disorder in pregnancy. So hypertension can complicate about 10% of all pregnancies. Now, this is a very, very important topic for exam. So lots of terms that we use. One, that there is pregnancy-induced hypertension or gestational hypertension, where patient develops hypertension after getting pregnant, and ideally 20 weeks after getting or after 20 weeks of pregnancy. So if a patient only gets hypertension after getting pregnant and basically 20 weeks after, like 20 weeks pregnancy and later, that patient only will be known as pregnancy-induced hypertension. That patient will only have hypertension but no proteinuria. But when a patient develops proteinuria with hypertension, it is called preeclampsia. A preeclampsia patient gets convulsion or seizure. That's what we call as eclampsia. So that's what we have written in here, pregnancy-induced hypertension. So if a patient gets hypertension, which means blood pressure above 140/90, occurring for the first time after 20th week of pregnancy, that's what we call as gestational hypertension or pregnancy-induced hypertension. Now we know about preeclampsia. Preeclampsia patient, so preeclampsia patient will have hypertension after 20 week of pregnancy, plus they will have proteinuria. That means they will lose protein in their urine. That's the time we call it preeclampsia. Preeclampsia can be divided again by mild and severe. So mild preeclampsia is when blood pressure is below 170/110. And then there is no other like complicated features. Severe preeclampsia is when blood pressure goes above 170/110. Along with that, there is complication, like patient has got kidney impairment, their platelet count has gone down, the liver enzymes has got up, persistent headache, epigastric tenderness. Okay, so any of the complications, if it is there, that becomes severe preeclampsia immediately. So that's mild and severe preeclampsia. It's mainly based on how bad is the hypertension, and also depends on the features. What about if a patient was hypertensive before getting pregnant? So that time you don't use the term pregnancy-induced hypertension. Okay, so we can only use the term pregnancy-induced hypertension if a patient has got hypertension for the first time after 20 weeks of pregnancy. Okay, Like let's say someone had mild hypertension, and then when they got pregnant, their blood pressure has got much higher. This time you will call it pregnancy aggravated hypertension. Okay? So let's say that you have got a pregnant patient who you suspect that it can be a case of preeclampsia. You will first check their blood pressure. So you will get that blood pressure is high. To diagnose a patient to be preeclampsia, you need proteinuria. So how to check proteinuria? First of all, you do a urine dipstick. In the urine dipstick, it will say 3 plus 4 plus protein. That's not a specific or definitive test for proteinuria. So to be sure, you can either do a spot urinary albumin creatinine ratio, ACR, or you can do a 24-hour urinary protein. Because 24-hour urinary protein takes time and it's a bit difficult. That's why the best test to check for proteinuria is urinary albumin creatinine ratio. Okay? Making sense, one? Okay, so gestational hypertension we discussed, and gestational hypertension will get better within 3 months after delivery. Preeclampsia, now you know the definition. So there is a specific criteria that what is proteinuria. So proteinuria means if the patient lose more than 300 milligram of protein in 24 hours. So we talked about that preeclampsia patients sometimes can have complications. So those complications can be, they can get renal failure, their liver enzyme can get high, like they can get impaired ALT, AST. They can also get a bit of inflamed liver causing epigastric tenderness or right upper quadrant pain. These patients can get neurological problem also, such as hyperreflexia. Clonus can be positive. They can get severe headache. They can also get persistent visual disturbance, like blurring of vision. They can also get hematological disturbance, such as thrombocytopenia. They can get hemolysis and fetal growth restriction. So the term that we use, that patient has got preeclampsia, when we say severe preeclampsia, these things will be there. The severe preeclampsia patient might have any of these features. And that's the time we call impending eclampsia. So features of impending eclampsia is persistent headache, blurring of vision, epigastric pain or right upper quadrant pain. And also you have got like this test can be positive, like they can have high ALT, AST, they can get hyperreflexia, they can also get thrombocytopenia. So all will be positive in impending eclampsia patient. Okay. There is another complication for preeclampsia. That is what we call as HELLP syndrome. So what is HELLP syndrome? So sometimes preeclampsia patient can be complicated by hemolysis, and then EL means elevated liver enzyme and low platelet. So that's called HELLP syndrome. And having HELLP syndrome is also a feature of severe preeclampsia or impending eclampsia. Okay? Chronic hypertension is patient who had high blood pressure even before pregnancy. Risk factor. So there are lots of risk factors. So can you repeat impending eclampsia? Impending eclampsia is when a preeclampsia patient has got severe feature. So severe feature can be any of those that we have discussed here. Okay, so renal insufficiency, liver problem, then they can get neurological issues, hematological problems. So any of this is there, that will be termed as impending eclampsia. So the risk factor for preeclampsia are all of this. You can go through this in your own time, not very important. And patients who develop proteinuria, they also get edema, which means that if you lose protein from your urine, what happens is that there will be interstitial fluid accumulation, which will cause generalized edema. So this kind of patient will come to you with their hands and foot and ankle getting swollen because they are gaining weight. And you will find out that they're actually getting fluid accumulation. So what are the risks? Why it is very important? Because it can cause a lot of complication for both mother and the baby. So management is the important thing that comes in exam. Because it is related to hypertension, so you need to keep the blood pressure down. The idea is to keep the blood pressure below 160 by 100. Okay? So what antihypertensive drugs that we can use in pregnancy? So contraindicated antihypertensive are ACE inhibitor, ARBs, and diuretics. The commonly used antihypertensive are beta blocker, like you can use labetalol, very common we use it. Then methyl dopa, nifedipine. So these are the common antihypertensive that you can use during pregnancy. When a patient with preeclampsia or if a patient who is pregnant has got a severe hypertensive crisis, for a hypertensive crisis, you can use IV labetalol, hydralazine, or diazoxide. But in a most of the situation, you are going to use labetalol, methyl dopa, or nifedipine. Okay, so let's talk about few other things. Treatment. So first of all, when you get a patient with preeclampsia, you need to first find out, is it a mild preeclampsia or is it a severe preeclampsia? That's the first thing, because the treatment is different. For a mild preeclampsia, you can just give them antihypertensive like methyl dopa or oral labetalol to keep the blood pressure down. And then you can send the patient to a high-risk pregnancy clinic where she will be seen by an obstetrician. But if it is a severe preeclampsia, the patient has risk to develop convulsion, which means eclampsia. And eclampsia is not good for a pregnant patient at all. So what we do for a patient who has got features of severe preeclampsia is you need to send them to the hospital, and the hospital will do a rapid control of blood pressure. So they are going to use IV hydralazine, they can use IV diazoxide, they can use IV labetalol. So those are the three common medications that can be used as an IV to bring down the blood pressure in severe preeclampsia. They will also use magnesium sulfate, which is something which can prevent preeclampsia, which can prevent eclampsia or convulsion. And if there is a possibility that there is a chance that baby might be born prematurely, less than 34 weeks, to bring the fetal lung maturity, you will also give a steroid. Okay? So for severe preeclampsia, that's the main treatment. Control the blood pressure with IV antihypertensive, give magnesium sulfate. Best treatment for severe preeclampsia is termination of pregnancy with early delivery by cesarean section or vaginal delivery if favorable. Now, it's not like every time a severe preeclampsia patient is there, you are going to just take the patient for a C-section. It's not like that. There is a lot of things inside. We'll come to that point just in a bit. But to give you an idea that if it is a patient who has got severe preeclampsia, based on their age of gestation or based on their pregnancy age, the treatment will be different. Like if it is a severe preeclampsia and patient is like, let's say 36 or 37 weeks, which means they are at term. By the way, what is term? Term means 37 to 42 weeks. So if the pregnant patient is near term or already in term, in that patient, if it is a severe preeclampsia, you would go for like either vaginal delivery by induction or cesarean section, because you don't need to wait anymore. But if it is, let's say, 32 weeks patient, in that case, you would try your best to prolong the pregnancy up to term. Okay, because that gives much better idea, or that gives much better care for the baby, because otherwise it will be a premature baby. Okay, so based on the age of pregnancy, the management will be different. Okay, but remember that once they reach the term, you would go for termination if it is a severe preeclampsia. And termination means you're going to go for delivery, not termination, like you're going to go for delivery either by C-section or vaginal. Let's say that severe preeclampsia patient now started to have seizure. When the patient will have convulsion, it will be eclamptic patient. Now that's the problem, because eclampsia, if it happens, whatever is the age of pregnancy, the best management is termination, that means delivery by cesarean section. Okay, so if eclampsia happens, then you don't try to prolong the pregnancy. You will go for cesarean section, or if it's favorable, then induction. So treatment of convulsion, when a patient starts convulsion, then definitely you will treat the convulsion first. You will give them magnesium sulfate to prevent further episodes of convulsion. If magnesium sulfate is not there in the option, then diazepam or clonazepam is another option. Now, this is a chart from Lillian Jones, which actually explains most of the things that I have discussed, especially about the management. Like, let's say, severe preeclampsia patient. For severe preeclampsia patient, they will get admitted, magnesium sulfate, and hydralazine, labetalol, any of the IV antihypertensive will be given. Okay. If you see about the mild to moderate preeclampsia, for mild to moderate preeclampsia, your choice of antihypertensive is oral medication. So oral methyl-dopa or oral labetalol or oral nifedipine. So that's the difference. When it is severe, you go for IV. When it is mild to moderate, you go for oral antihypertensive. And mild to moderate, you don't give magnesium sulfate. But for severe, you give magnesium sulfate. Okay? So is there any prevention of preeclampsia? So according to Lillian Jones, they say that prophylactic aspirin given to women at high risk of developing preeclampsia, especially if someone who has already known case of hypertension, type 1 diabetes, previous pregnancy was complicated with preeclampsia, for the high risk patient, you can give them prophylactic aspirin and it can reduce the risk of preeclampsia. Calcium supplementation can reduce the risk of gestational hypertension and preeclampsia. Okay, so either calcium or aspirin, these two is good for prevention of preeclampsia in a high risk patient. Now, this is where they have discussed, depending on the age of pregnancy, what should be your management. Okay, so we had a good discussion already. Let me just go through it. Preeclampsia diagnosed before 32 weeks of pregnancy. Before 32 weeks of pregnancy, the objective is to keep the fetus in utero until at least 35 weeks or longer. Because by the time baby is 35 weeks, the lung will be mature enough. So for preeclampsia patients who are diagnosed before 32 weeks, your best choice would be to prolong the pregnancy. If you can, up to term. If you can't, then at least up to 35. And you will be monitoring the baby like with ECG, ECG, CTG, like cardiotocogram. So you'll be doing the monitoring every week. Okay, and if preeclampsia worsens during the pregnancy, then yes, then pregnancy, like then you will need to go for termination, usually by C-section. But before 32 week of pregnancy, the idea is to prolong if you can. Same between 32nd to 35th week, the management will be same. So if you can, you will prolong the pregnancy up to term, up to 37. But if you can't, if it becomes severe preeclampsia, after 35 week, you can consider going for termination, either by C-section or induction. Okay. What about after 35th week of pregnancy, patient has got preeclampsia. So if preeclampsia is diagnosed after 35 week, especially severe preeclampsia, then you can go for induction of labor or C-section. Women with preeclampsia should not be allowed to exceed full term because risk of intrauterine death is really high after term. So by that time they are 37 weeks, you would not wait any longer. Okay, so between 35 to 37 weeks, you will just try to see that if you need to go for elective C-section, or you can try to go for induction. Okay. So that's pretty much preeclampsia management. So idea is that if it is a mild preeclampsia, you will try to just keep the blood pressure normal and then keep it under monitor and try to prolong the pregnancy. If it is severe preeclampsia, then if you can, you will try to prolong the pregnancy up to 35 at least. But if there is severe or impending preeclampsia or impending eclampsia feature, and the pregnancy is already 35 weeks and above, then the best idea would be to go for either C-section or induction. Okay? Does it make sense for everyone? No, not a single reading. So single reading of hypertension is not enough to confirm hypertension. So you need at least 3 or minimum 2 in a separate session. So minimum 2 hypertension is needed to diagnose any hypertension. We give a steroid for lung maturity if there is a risk that the child might be born before 32nd. Yes. Is it a good option to induce labor? Yes, if it is, like we say, if it is favorable. The best is always elective C-section if it is better, but you can try induction of labor. It's fine. It's not like contraindicated. So eclampsia management. So the most important eclampsia management is magnesium sulfate because it reduces the risk of recurrent seizure. You can give it intravenously or IM injection. The regimen of magnesium sulfate, the dose comes in exam. So you need to know that what's the dose that we give. So loading dose of 4 gram and then maintenance is 1 gram per hour in a solution of 5 in 500 ml of normal saline. You can just remember 4 gram as a loading dose and 1 gram for 24 hours. That's usually the treatment. Now, magnesium is excreted by kidney and it is a smooth muscle relaxant. So what if you give too much magnesium? Patient can develop magnesium toxicity. So to make sure that patient doesn't get developed magnesium toxicity, you check 3 things. You check their reflex, that means the tendon reflex, you check the respiratory rate, and you check the urine output. So if patient's respiratory rate is too high, or patient getting respiratory arrest or respiratory depression, what would you do? If patient gets respiratory arrest or respiratory depression, in those cases, you have to stop the magnesium sulfate and give the patient calcium gluconate IV. Calcium gluconate is an antidote for magnesium toxicity. If a patient has absent patellar reflex, then if respiration is normal, you can stop the magnesium until reflex return, and then you can restart once reflex is back. So absent patellar reflex, if respiration normal, then you would stop the magnesium sulfate until reflex return. Poor urinary output. If there is no other sign of toxicity, you will reduce the rate of IV infusion from 1 gram per hour to 0.5 gram per hour. Okay, so this comes in exam. So they give you a magnesium toxicity scenario and then they ask you what would you do next. Okay. Medical treatment. So we talked about medical treatment already. Once good control of the blood pressure and convulsion has been obtained, pregnancy should be terminated. So that's for eclampsia. So once you control the blood pressure and the convulsion, then pregnancy needs to be terminated. Okay. And termination is usually by C-section. So that's all about preeclampsia and eclampsia. Any questions from here, guys? And Dr. Sherish, so I know you are new. Let's finish the obstetrics and then we can discuss about what QBank or past papers. Okay. And for anyone who joined the course as a new, you need to go through our orientation class video because we are in the middle of the course at the moment. And I know it is tricky for a lot of you to just start in the middle, but the thing is that we discussed whatever you are asking at the moment. So what you need to do is to go through our orientation session. There is a video in the portal and that will answer all of your queries that you might have. But at the end of the class, if you want to know anything, just ask me, not in the middle of our classes. Okay. If eclampsia, termination is indicated at any gestational age. Okay. But sometimes, like if it is only one convulsion and everything else looks fine, mother, baby, everything is stable, you might try to prolong. And if second episode happens or there is distress of the baby or mother, then definitely termination. So those are case by case, which doesn't come in exam. But in reality, you might wait. Okay, if it is like, let's say, if it is a less than 32 weeks pregnant and having a eclampsia, you might want to wait at least one more time, as long as baby and mother is stable. And severe preeclampsia and HELLP syndrome, we discussed about like case by case according to the gestational age. We will change our management. Okay, moving on to next topic, which is anemia. Till what week we need to give steroid? Up to 32. Sorry, up to 34. Sorry, that's my mistake. Up to 34. Okay, anemia during pregnancy. So during pregnancy, as long as the hemoglobin is above 110, that's normal. Anemia is defined if hemoglobin is less than 110 gram per liter. So what is the most common cause of anemia in pregnancy? The most common cause is iron deficiency anemia, about 50% cases. Other than that, it could be megaloblastic anemia due to folic acid deficiency, or sometimes less commonly thalassemia. Thalassemia is not very common in Australia. So don't think thalassemia as your first cause. Okay. So let's say that you have got a pregnant patient who is very tired, fatigued, feels short of breath, and you have checked their hemoglobin level. And you found that patient is anemic, like hemoglobin less than 110. What will be your next investigation, guys? Yes, iron studies will be your next investigation of choice. Let's say iron studies shows iron deficiency anemia, or the iron study shows that ferritin level is very low. So if ferritin is low, that indicates iron deficiency. Remember, if serum iron, like total iron, is low, but ferritin is normal, that means there is no iron deficiency. As long as ferritin is normal, iron is normal. Okay? If ferritin is low, then you can say it is iron deficiency. If it is iron deficiency, you need to find out what's causing it. Is the patient is a vegetarian? Because if vegetarian, they don't take that much of a red meat, so that causes iron deficiency. If they're bleeding from anywhere. Sometimes pregnancy itself can cause iron deficiency because the baby actually feeds mother iron to get bigger. So you need to find out what's causing it, and if you can, treat the cause. But you need to start the patient with iron tablet. Okay? If it's not getting better and ferritin is too low, sometimes they might also require iron transfusion. Let's say you have done iron study, but iron study comes normal. What will you do next? Then you are going to check the B12 and folic acid level. Yes. So if B12 and folic acid level is low, so any of this can be low. So if B12 is low, then you will give them B12. If folic acid is low, then you'll need to give them folic acid. And let's say iron normal, B12 folic acid normal. Then only you will go for hemoglobin electrophoresis. So that's the step-by-step screening or investigation that we would do. Okay. They don't give you iron steady or ferritin as an option. Okay, because that's not actually a good option. But if you actually get something like that, iron steady versus ferritin, ferritin is specific, so you would choose ferritin. No, we don't give routine iron in Australia. We only give iron if patient has, like if the blood test shows patient has deficiency, then only patient is given that. It's not a routine thing. And yes, Dr. Asfar, first you do the complete blood count and then you do iron studies. No, we don't give, if it is normocytic, then we don't give iron. We only give iron if it is iron normal. Like if iron is deficient. Okay? So usually normocytic anemia is not common in pregnancy. Moving on, diabetes mellitus. So diabetes can be a very complicated thing in pregnancy. So especially if it is a type 1 diabetes. So type 1 diabetes means they are already taking insulin. And sometimes during pregnancy, they might need increased dose of insulin during pregnancy. Because in pregnancy, sometimes the blood glucose can get a bit worse because of pregnancy hormones. Okay. So if we can't control diabetes during pregnancy, there is always a risk for both baby and the mother. So you can read those risks in your own time. But most importantly, the baby who has, like baby with mother who has uncontrolled diabetes can get quite large. So macrosomia, fetal abnormality like neural tube defect, multiple organ defect, all of this can happen. So that's why it is very important to control the blood sugar during pregnancy. So if you have got a type 1 diabetic patient during pregnancy, early referral to a diabetic physician and obstetrician is the best management. That means you need to include an endocrinologist and an obstetrician for best management. You need to assess the basic parameters, so blood sugar level, HbA1c, all of the things. You can see the insulin requirement in pregnancy can get more than 2 to 3 times. And you need to assess the baby for any fetal abnormality. So baby will get ultrasound from 18 weeks and every 4 weekly thereafter. The aim of delivery would be vaginal, but if the baby is very big, like more than 4 kilo, in that case, C-section will be indicated. Okay, so type 1 diabetes during pregnancy, you just need to remember that there is a risk of like macrosomic baby and insulin requirement might be increased. They don't usually ask you the dose of insulin in exam, so you don't need to be a pro in this. Just remember the things that I have discussed, and that will be enough. Okay, so most of the diabetic mother, they can have a normal vaginal delivery unless if the child is more than 4 kilo or there is any sign of fetal distress, they will need C-section. And the delivery can happen during term. Very important topic for exam is gestational diabetes. So gestational diabetes is just like pregnancy-induced hypertension, gestational diabetes if a patient get diabetic first time during pregnancy. Okay, so before pregnancy, patient did not have any diabetes, but when they're pregnant, during pregnancy, if you diagnose them as diabetes, that's gestational diabetes. So if you suspect, like maybe you have done a random blood sugar and that's very high, then you would suspect, well, that could be a diabetes. So if you suspect that the patient can have diabetes, the only way to confirm it is to do a diagnostic OGTT, which is oral glucose tolerance test. Now, every pregnant patient, we do some regular screening for them in Australia, everyone. They have a proper antenatal care schedule. So one of the antenatal care schedule is by the time they are 26 to 28 weeks, every pregnant patient in Australia will get a sugar test or OGTT, even if they don't have any risk. Okay, but there are few group of patients who needs to have this OGTT in the first antenatal visit. So it should be performed in the first trimester or first antenatal visit if there is a strong family history of diabetes or if the patient had previous gestational diabetes. Okay, so in these two situations, you would do it in the first trimester blood test, but in all other cases, you can do the OGTT between 26 to 28 weeks. So what is abnormal OGTT? So you have given 75 grams of glucose for the patient to eat or drink, and then 2 hours after the glucose drink, you measure the blood sugar. 2 hours after the glucose drink, if the blood sugar is above 8.5, that gives you the diagnosis of gestational diabetes. Or if you will also do one fasting, if fasting is more than 5.5. Okay, so for gestational diabetes, there is always a risk. So the same risk can happen like macrosomic baby, intrauterine fetal death. So lots of complications are there. So what will be the management? First of all, for gestational diabetes, there is a RACGP guideline. And I would like all of you guys to follow the RACGP guideline for gestational diabetes, because this guideline is 6th edition that has been changed, but RACGP guideline is new guideline. So follow the RACGP guideline for gestational diabetes, okay? But the management stays the same. So management for gestational diabetes, first of all, you would try a lifestyle modification with dietary change and bit of exercise. And you try this for 2 to 3 weeks. And you ask the mother to check their blood sugar at least 4 times a day. And then you review how is the blood sugar after lifestyle modification. If blood sugar is sky high, so like super high, then most of the time they will need insulin. So insulin is the choice of medication for gestational diabetes. But let's say after lifestyle modification, blood sugar is not super high. Like maybe the normal is fasting 5.5 and they are just staying at 7.5. It is still high, but it's not super high. Super high would be like, let's say 12 fasting. That's very high. So if it is just a mild elevation, in those cases, you can try with oral antihypoglycemic, which is metformin. So in Australia, I know that we use metformin in pregnancy, especially for this kind of like mildly elevated blood sugar. But in case of very high blood sugar, the best management is definitely insulin. Okay? And for gestational diabetes, also your aim of delivery will be at term, and normally you would go for vaginal delivery. Now this comes in exam. How to follow up gestational diabetes patient after delivery. According to GEM, they say that follow-up should be done by a OGTT at 6 weeks, and then every 5 yearly they need to have a OGTT. That has been changed by RACGP. Okay, so I want you guys to go to RACGP guideline and give it a rate about this follow-up. Okay, they say that you need to do a OGTT. You just need to do a fasting blood sugar or a HbA1c. Okay, so go through the RACGP guideline for this. The question also comes that if a patient has got gestational diabetes, what is the risk of subsequent pregnancy to have gestational diabetes? So it's a very high risk. So if a patient got gestational diabetes, the next time they get pregnant, very high. But the important thing to know that why we do this follow-up is because 30% of gestational diabetes patient later on will become full diabetic. Okay, so that's why this follow-up is necessary. And Dr. Sana, it is different. Every patient has got different kind of like comorbidities, different kind of situation. For Asian patients, they don't want to take those risks because Asian patient has got more risk, especially their diabetes is very difficult to control sometimes. So for those patients, they go for like insulin most of the time because that is a high risk population. Okay, so it's case by case. But as I said, if question asks you in the exam that after lifestyle modification, what will be the choice of medication, that will be insulin. Okay, so insulin is the choice. But as I said, case by case, sometimes we do give metformin. It's not that we can't. Okay, so it is practical scenario, but in case of exam, it will be insulin. let's open this RSCGP guideline so that we can go through this. So they have given some diagnostic criteria also for the gestational diabetes. And what are the risk factors? You can see that Asian, Indian subcontinent, they are high risk for diabetes. So lifestyle modification is the first thing that we try, because in 50 to 70% cases, you will be able to maintain a normal blood sugar just by maintaining a good diet and appropriate exercise. So that's the first thing that will be tried. What is the target for fasting blood sugar? In this case, the fasting blood glucose target is between 4 to 5.5. So if we can make it in this target, that's really good. And they have also given the target fasting less than 5, 2 hour less than 6.7. Okay. Pharmacological treatment. Metformin with extended release formulation has not been shown to harm mother, fetus, or child. Approximately 50% of women who commence metformin obtain satisfactory glycemic control. However, for those women who ultimately require insulin, use of metformin can result in a delay in achieving optimal glycemia. If blood glucose are substantially elevated, that's what I say, Dr. Sana, it is preferable to promptly institute insulin therapy. Okay? Use of metformin is contraindicated in the context of preeclampsia or fetal growth restriction. So that's actually the thing, that metformin is like very rare, like not very commonly that you would use it, but it can be used. Definitely, if blood glucose is very high from the first, then yes, this is not an option. Insulin is the option. Insulin treatment is safe and effective and usually the first choice of pharmacotherapy for GDM. So it is important that all women who has gestational diabetes have an OGTT to clearly document their glycemic status after the pregnancy. This testing is usually done at 6 weeks to 3 months postpartum. So this one, that means after delivery, the first follow-up that the patient will have between 6 weeks to 3 months, that will be OGTT. And then in terms of long-term follow-up, they say that annual measurement of HbA1c is simple and practical. So that can be done. Another recommendation is doing a fasting blood glucose every 1 to 2 yearly. So that's the new guideline at the moment. We don't need to do every 5 yearly patient doesn't need to get a OGTT. So the first one, after 6 weeks, you can get a OGTT, and then every year patient can just get one HbA1c. That will do. Okay. So that's the follow-up. Next, yes, insulin is our first line option in case of exam purpose. Okay, so in exam, if after dietary modification they are asking that fasting blood sugar, like the blood sugar is not well controlled, what will be your next option? That will be insulin. Thyroid disorders. So thyroid disorder in pregnancy is not very common and it's not very important as well. But if a patient has got thyroid disorder, there is a high rate of miscarriages. That's why normally, if there is a past history of thyroid disorder, we check their thyroid function in the first trimester. And also we do it at 36 weeks. Okay. Sometimes if it is a hypothyroid patient and they get pregnant, then you need to give them thyroxine. So thyroxine dose might be increased during pregnancy. So you need to check their THAs and T4 quite regularly to change the dose. How about hyperthyroidism? Hyperthyroidism is usually caused by Graves' disease, and propylthiouracil is usually the preferred agent. So this comes in exam sometimes, like let's say a Graves' disease patient now is pregnant. What will be your choice of anti-thyroid medication for her? So the common anti-thyroid that we use is carbimazole. But carbimazole is contraindicated in first trimester. And first trimester means up to 12 weeks of pregnancy. So during that first trimester, you would use propylthiouracil because that is not contraindicated. Once patient pass the first trimester, then you will change this propylthiouracil to carbimazole again. Okay, so that's the management for hyperthyroidism during pregnancy. What happens if a patient has known kidney disease? Only thing that is important that with a patient who has known kidney disease and now pregnant, there is a risk that baby can become intrauterine growth restriction. Like IUGR is very common in a uncontrolled or kidney failure patient who is pregnant. And you can go through the other things in your own time. SLE during pregnancy. Not very important, but SLE during pregnancy has a high risk of preeclampsia. It has high risk of miscarriage. Lupus patient, if they get history of recurrent miscarriage and recurrent venous thromboembolism, what is that condition called, guys? After first trimester, propylthiouracil is not contraindicated. But the best medication is carbimazole. That's why we switch to carbimazole. Yes, antiphospholipid antibody syndrome, right? So SLE patient, they have a high risk of thrombosis. So for SLE patient who is pregnant, to reduce the risk of venous thromboembolism, you will put this patient on aspirin or low molecular weight heparin from 14 weeks of pregnancy until 6 weeks postpartum. Okay? It's also applicable for any patient who is high risk of deep vein thrombosis or pulmonary embolism. Like who has got recurrent deep vein thrombosis history and they are pregnant, you would be putting them on low molecular weight heparin most of the time from 14 weeks until 6 weeks. Okay. And during pregnancy, if SLE patient can continue a steroid because that's safe and it's not contraindicated. So that's what's written in here. Low dose aspirin or low molecular weight heparin can be used to reduce the risk of clot. Low molecular weight heparin is preferred for deep vein thrombosis patient. If a patient going for delivery, during delivery, you stop the low molecular weight heparin and you change it to unfractionated heparin. Okay, because unfractionated heparin, it's usually the half-life is very low or very less. So you will change it from low molecular weight heparin, which is a subcut, to unfractionated heparin, which is IV. And again, guys, what I want you to understand that the only thing that is important for your exam, that's what I'm going to discuss with you. I know you might have a lot of questions, But things that is not important, please don't ask it, because we can't finish your obstetrics if you go in that much of a detail. Like how many hours before delivery we need to change the low molecular weight heparin to unfractionated. It will never ever come in your exam. So talking about that, it actually makes it difficult for us to finish what is important. Okay, so I want you guys to understand that if you guys want best from me or the important things from me, you need to make it in a way so that I can discuss things that is important. Okay, so I hope you guys understand that fact, because I can discuss one topic for an hour, but what will happen that after 2 class I can't discuss obstetrics, which means that I have to cut short few things which will important. Okay, so I want you to understand that because I know that it's difficult sometimes, and also try to understand that repeating things multiple times, it also takes time from the class, right? Like it's not very hard to understand that from 14 weeks of pregnancy you need to start aspirin or low molecular weight heparin up to 6 weeks postpartum. And I have also written on the board that yes, this is the time period. So still after that, if someone asks me to repeat that, it means you are not paying attention. Okay? So that's very important that you guys pay attention so that I don't need to repeat things multiple times. Okay? I understand that you want me to repeat important things many times, but it's just what happens that you would miss things that is important. And I want to give the important things in the class so that you don't need to get confused in the exam. Okay? When to give aspirin, when to give low molecular weight heparin, Dr. Nisha. So it's like you can use any of them. There is no specific thing. So either aspirin or low molecular weight heparin. It's just your choice. Thrombocytopenia during pregnancy. So the two most common cause of thrombocytopenia in pregnancy is, one is gestational thrombocytopenia, which is more common, and another is less common, immune thrombocytopenia. And then there are other causes as well. Now, it's not important for exam. You can give it a read in your own time. So we don't need to discuss this in the class. Immune thrombocytopenia is not also important, so doesn't matter. Jaundice is specific to pregnancy. So there is a condition called cholestasis of pregnancy that sometimes comes in exam. So we'll discuss that. And if the question asks you that what is the most common cause of jaundice during pregnancy? That's viral hepatitis. 40% cases, that is the cause of jaundice during pregnancy. Two specific condition that causes jaundice in pregnancy is one cholestatic jaundice and another is acute fatty liver. Acute fatty liver is very severe and very serious, but it's very rare as well. It doesn't come in exam. So cholestatic jaundice means that kind of like, you remember, if we might have discussed that. So this is the gallbladder, and then we have got cystic duct, then hepatic duct, which together makes common bile duct. In common bile duct, if the bile gets obstructed or it gets like very thick, it can cause cholestasis. Cholestasis is common in the latter half of pregnancy, which usually presents with jaundice and itchiness in the body. The problem with this is that it can cause fetal distress. Okay, so for this patient, if you see that this patient has got features of obstructive jaundice, like their bilirubin is high, direct bilirubin is very high as well, and their alkaline phosphatase is super high, that means it is cholestasis. In that case, you would check their liver function definitely, and you can give them vitamin K supplementation. And ideally, for a cholestasis of pregnancy, your aim should be to go for delivery near term. Okay, and this condition usually get better after delivery, but there is a chance that it can recur in future pregnancies as well. And we say that if a patient has developed cholestatic jaundice during pregnancy, we don't give oral contraceptive to that patient anymore because it increases the risk. Acute fatty liver is not important. Epilepsy in pregnancy. So epilepsy in pregnancy is important, and there is lots of questions and complicated questions come in exam from here. So let's discuss a little bit. So a patient who is pregnant and a known case of epilepsy, how you are going to proceed and what will you say to that patient? The problem is almost every anti-epileptic medication is teratogenic, which means that it can cause effect on the baby. So you can see here all anti-epileptic drugs are potentially teratogenic, with different drugs has different effect. Like phenytoin, which is not commonly used anymore, can cause cleft lip, cleft palate, congenital heart disease. Sodium valproate, which is commonly used, and carbamazepine can cause spina bifida. Okay, so that means that all the common ones which we can use has some kind of risk. That's why managing epilepsy in pregnancy is difficult. And it also says that pregnancy itself can increase the risk of seizure. So you can't just stop anti-epileptic medication for everyone. Okay, so for a patient who has known epilepsy, first thing you advise them to take a high dose folic acid during pre-pregnancy and up to 12 weeks gestation. So every patient who is pregnant, they will take folic acid in the first trimester. Okay, this is the usual one which everyone takes in Australia, not iron, folic acid. Okay, but the common dose of folic acid is just 0.5 milligram once a day. But for patients who are epileptic, you will need to give them an increased dose, which is 5 milligram. Now, the question that comes in exam is a patient, let's say a patient came to you for pre-pregnancy counseling and she is a known epileptic. She takes sodium valproate. Okay, and they say that for the last 2 years she did not have any seizure. That means her seizure is well controlled. So well controlled seizure and patient came before getting pregnant, you can do something. So what you can do is you can advise the patient that because your seizure is well controlled and sodium valproate has significant risk on the baby, we can stop the sodium valproate before you become pregnant. So what you would do that you would gradually reduce the dose of valproate, and then over a period of time you will stop the valproate. Okay, so if you stop the valproate, because there is always a risk that patient can get epileptic attack during pregnancy, so we will change the valproate to something which is less risky. So you would change to either carbamazepine, that's less risky than valproate, or even the newer antiepileptics. So newer antiepileptics like lamotrigine or levetiracetam, commonly known as Keppra. These are newer antiepileptic, lamotrigine, levetiracetam. these are not that much teratogenic like the initial ones. So you can either change them to carbamazepine or the newer antiepileptic, and patient can continue it during the pregnancy. Okay. Now let's say if now this all depends on the neurologist, definitely. If someone is like for 3-4 years, there is no seizure at all, you can give them, like neurologist can make a choice that they can give a medication-free first trimester. So in the first trimester, they can stop all antiepileptic, and from the second trimester, they can start the antiepileptic. So a medication-free first trimester, that can be another choice for a very well-controlled epileptic patient. But that depends on the neurologist at the end. But the main option or main thing that comes in exam is this one. Sodium valproate patient came for counseling before getting pregnant. What would you do? You would change it to something safer. Okay? What if patient is already pregnant and came to you that I'm now 8 weeks pregnant, but I'm taking sodium valproate? You can't do anything. You will just say that because you are already pregnant, we can't take the risk of stopping the valproate because then there is an increased risk of seizure. So as already you have been taking it, there will be a risk of like some of the side effect, but we will keep an eye. We will make sure to do morphology scan and frequent ultrasound to find out anything happens as early as possible. So if once they are pregnant, there is no point of changing the medication. Does it make sense for everyone? Sometimes they also ask that which antiepileptic is safest for a breastfeeding mother. For a breastfeeding mother, sodium valproate is best and safe, and also the newer antiepileptics. Okay. All good, everyone? Okay, let's take a 10-minute break now, and then we will start with placenta previa and placental abruption. 10-minute break, guys. Thank you. All right, everyone, let's continue. So, the next topic is antepartum hemorrhage. So, antepartum hemorrhage, and then there is postpartum hemorrhage. So, antepartum hemorrhage, the definition is bleeding from the genital tract after 20th week of gestation and before onset of labor. After onset of labor, if it is, or you say that during delivery and after delivery, if there is bleeding, that's postpartum hemorrhage. Okay. So from 20th week of pregnancy up to labor, if during this time, if a patient has got parvaginal bleeding, that's antepartum hemorrhage. We say that if hemorrhage occurs less than 24 weeks, then it is called miscarriage. There are mainly two causes of antepartum hemorrhage, which is placenta previa and abruption of the placenta or abruptio placenta. Both of these are very, very important for exam. So placenta previa means normally, if you see here in a normal patient, if this is the uterus, the placenta should be on the fundus, which means on the top part of the uterus. But if placenta starts to come on the bottom of the uterus, that's what we call as placenta previa. So when placenta has a low attachment on the lower uterine segment, and sometimes it can cause like obstruction of the opening of the internal os or opening of the cervix, that is what we call as placenta previa. The problem with placenta previa, if you look on this picture, so at some point the baby will start to descend downward, right? And baby will become bigger and bigger. So if placenta is staying on the lower end, when baby starts to descend downwards, it can start compressing this placenta. And sometimes there are lots of small immature blood vessels over here, and it can get ruptured and it can cause the parvaginal bleeding. So it causes a painless parvaginal bleeding. Okay. So it's very easy to diagnose that painless parvaginal bleeding after 20th week of pregnancy, most likely placenta previa. There are 4 grades of placenta previa, grade 1 to 4. Grade 1 is low-lying placenta. So placenta is just on the lower side, but it's not covering the os. Marginal, which is just a little bit. Marginal is actually up to this. So it's just at the edge of the os. So these two, which grade 1 and 2, is called minor placenta previa. Partial previa is when it covers most of, you can say it covers most of the internal os. And when it covers the full internal os like this, that's complete previa. So this is grade 3 and grade 4. That's what we call as major placenta previa. Definitely major placenta previa has high risk of bleeding, and also the management is different from minor to major. So what is the main management for a pregnant patient coming to you with a sudden onset of parvaginal bleeding? Because this bleeding sometimes can be a heavy bleeding, especially for major grade. First thing is definitely resuscitate the patient. So insert an IV line, send the blood for cross-matching and hold, start the patient with IV fluid. So resuscitation, and then you confirm the diagnosis by doing an ultrasound. An ultrasound will give you an idea that is it a minor or major grade of placenta previa. It will also give you an idea how is the baby doing. If it is a major placenta previa, and we say that if the patient is after 34 weeks of pregnancy, you'll need to keep the patient admitted to hospital until delivery. So major grade, especially after 34 weeks of gestation, admit the patient to hospital for observation. Keep an eye on the patient, see that if the bleeding gets stopped. And and also look an eye for mother and the baby. If bleeding continues or mother or the baby becomes unstable, then for major grade, you will need to go for cesarean section. Cesarean section is not indicated for major placenta previa because, vaginal delivery is not indicated for major placenta previa because you understand that it will be very difficult for the baby to pass this placenta and go and descend downwards. So for grade 3 and 4, vaginal delivery is contraindicated or it's not possible. But for this, like low-lying placenta, there is a possibility that baby can actually can go down. Okay, so for those patients, if an obstetrician agrees, then they can try a vaginal delivery. Okay. So cesarean section is always required for major placenta previa, but there is just a very small group of patients can have a trial of vaginal delivery. Elective cesarean section is usually performed at 37 weeks. So let's say that you have got a patient who has got major placenta previa and patient is 34 weeks gestation. So you will definitely admit the patient and you will keep the patient admitted. So you will keep an eye. Let's say the mother and baby is stable, bleeding is stopped. Okay. So your idea would be that by the time it is 37 weeks, you will arrange an elective C-section for the patient. Okay. So that's more or less about placenta previa. Any question, guys? Placental abruption. So what is abruptio placenta? So if you look over here, that placenta is attached with the uterus, right? And placenta will be detached only after the delivery of the baby. That's how it should occur. But before delivery, if placenta get detached from the uterine wall, that is what we call as placental abruption. So when it get detached, what can happen that patient can start bleeding from here. And the bleeding can be two types. One, that blood can accumulate in the uterus and the uterus can get larger and tender. That's called concealed variety of placental abruption because bleeding is not coming out, rather it's collecting inside. And then there is a revealed variety of placental abruption where the blood will not accumulate, rather it will come down as a very severe PV bleeding. Okay, so there are two types of placental abruption. One is concealed variety where blood will get accumulated. Because it gets accumulated, uterus will be very large. So you will find out that uterus is larger than the gestational age. So we say that gestational age usually correlate with the symphysiofundal height or height of the uterus. So if gestational age is 30 weeks, the uterine height should be between 30 plus minus 2 centimeter. So between 28 to 32 centimeter is normal. But now, because uterus is getting larger because of blood getting accumulated, you will find out that 30 weeks pregnant patient, their uterine height might be 36 centimeter. So there will be symphysiofundal height greater than the gestational age. So that's one of the findings that you can get in concealed variety. But for revealed variety, there will be no accumulation. So more or less same height will be there. Okay, but you'll get more or more PV bleeding in that patient. Make sense? So in this patient usually gets painful PV bleeding. So painless PV bleeding is placenta previa and painful PV bleeding is placental abruption. So this patient presents with abdominal pain, bleeding parvaginally, and a tense and tender uterus which is large for gestational age. And because the patient can bleed heavily, they can go into hypovolemic shock. So what is the cause of abruptio placenta? It's very hard to find out, but multiparities, cigarette smoking, cocaine abuse, any of these can cause it. Hypertension during pregnancy, with or without preeclampsia, can be one of the major risk factors. So how we are going to manage a patient who is bleeding heavily like this? So definitely admit the patient. Resuscitation is the first thing that you do. And then you send the blood for some tests. So you do full blood count, you send the blood for cross matching. So you do some blood test. Then you do ultrasound and CTG. Ultrasound to exclude placenta previa and to find out how the baby is doing, and cardiotocogram also to assess fetal cardiac activity. Okay. Steroid if child is less than 34 weeks to bring the lung maturity. So your first management is definitely resuscitation. Once resuscitation is done, then you get all the tests and you confirm the diagnosis. Once it is confirmed, the management will depend on a lot of factors. First factor is how is the baby and mother. Few things can happen. Let's say baby and mother is stable and bleeding has stopped. Okay, so in that case, you can continue the pregnancy up to 37 weeks. So if it is stable, you will continue the pregnancy up to 37 weeks. And once 37 weeks is there, you will go for induction of delivery. Okay. How about mother or baby is unstable, like fetal distress, and it's not that you don't have any time to save the baby mother if you don't do anything right now. So for unstable case, you have to go for either you can go for C-section. So cesarean section has been recommended where baby's life is immediately threatened. Okay. So if it is really like child is in fetal distress, mother is in shock, then C-section. If C-section is not possible, then you can go for induction. But C-section will be ideal for unstable case. Okay. There is a possibility always that because mother gets into shock in case of heavy bleeding, there is a risk of intrauterine fetal death in this case. So if baby is dead because mother is bleeding a lot, in that case, what would you do? You would not go for C-section at that time. You would go for either you can wait for a spontaneous delivery or you can also go for induction, like an artificial rupture of membrane. Okay, so that's usually the management for abruptio placenta. And the trauma is the same thing, Dr. Fatima. So in case of trauma, the main complication that can happen is abruption. So in abruption, the management is same. So trauma is not the main part. Main part is what has got complicated because of trauma. So if because of trauma patient has got abruption, then the treatment will be same like this. For an unstable patient, Dr. Chandima, you are doing C-section. So it doesn't matter what is the gestational age. So if it is unstable, you need to go for C-section at any gestational age. So in cases of severe bleeding, urgent treatment to deliver the baby is required, irrespective of the gestational age of the fetus. If bleeding is less severe, you can do wait and watch. Okay. If bleeding recur, then you might need to go for the delivery. An episode of severe bleeding may lead to urgent delivery, but in most cases, pregnancy can continue until term. So we try our best to continue until term as long as baby and mother is stable. So this is the revealed variety. You can see the PV bleeding, and this is the concealed variety. There is a difference between placenta previa and abruptio placenta given here, but the main is placenta previa is painless, abruptio is painful. Now, there is a condition called vasa previa. So vasa previa is a very rare cause of antepartum hemorrhage due to rupture of the fetal blood vessel. Let's say that you were trying to go for induction of labor by doing a rupture of the membrane. So when you tried to do an artificial rupture of membrane, somehow you also nicked the baby's scalp. And if you do that, baby's scalp will have blood vessels, and then the baby will present with bleeding. So it coincides with the rupture of membrane. So with the rupture of membrane, if there is a bit of PV bleeding because of rupture of fetal blood vessel, that's what we call as vasa previa. And in this patient, you will need an urgent C-section. Not very important for exam. If you want to know a little bit more, you can go through this guideline. Next, primary postpartum hemorrhage and secondary postpartum hemorrhage. Do you guys have any questions about placenta previa or abruptio placenta? So primary PPH is if a patient had more than 500 ml of blood loss within 24 hours of delivery. Okay, so from the onset of delivery up to 24 hours, if there is a bleeding more than 500 ml, that's primary PPH. After 24 hours of delivery, up to 6 weeks postpartum, if there is a bleeding, that's secondary PPH. So what is the most common cause of primary PPH? Uterine atony. So uterine atony is ideally after delivery of the baby and the placenta, the uterus should be contracted because this contraction of the uterus helps for the bleeding to be stopped. But there are some patients where uterus gets soft and lax. So soft, lax uterus after delivery is what we call uterine atony. And that's one of the cause of primary PPH. Retained product of placenta could be laceration of the genital tract like perineal tear, episiotomy wound is getting bleeding, vaginal tear, cervical tear, okay? Rupture or inverted uterus or coagulation disorder. So this can be all the cause of PPH. So what is the management of primary PPH? That comes in exam a lot, okay? So the first thing, out of anything, the first thing that you do, if you feel that uterus is soft and lax, in a primary PPH patient, your first management is fundal massage. Always remember that. Okay, so fundal massage means you start massaging the fundus of the uterus and that will cause contraction of the uterus. And that can stop the bleeding if it is because of atony. So that's the first thing, rubbing the fundus or fundal massage. Once you have done that, or you will keep doing that, you will also do the resuscitation. So IV line, take the blood, start fluid. Once blood is available, then give blood. Okay? During that time, what else would you do? You can also give, like you would look for a few things. So you look at the placenta to see that if placenta is full or if there is a possibility of a retained placenta. You can also check very quickly perineal area and episiotomy on to make sure none of bleeding is not coming from there. You will also start with IV oxytocin. And if IV oxytocin itself is not helping, then you will add IV or like you'll add IV or IM argometrin. Okay, so that's usually up to where you need to know the management. There is a lot of management after that, but you don't need to know that. Okay, so first of all, fundal massage, then resuscitation, IV line, then take the blood, start IV fluid, and then start blood when it is available. Then make sure placenta is not incomplete. You can also catheterize the patient because full bladder can aggravate the bleeding. Make sure there is no tear. Give the patient oxytocin or syntocinon, argometrin, and then if still patient bleeding, the option will be giving misoprostol per rectum. Sometimes even patient might need bimanual compression. Sometimes at the end, even hysterectomy. So lots of options are there, but that doesn't come in exam. You can see if a persistent atonic uterus is not controlled by oxytocin, then even intramyometrial prostaglandin might be needed. So this is some of the other step-by-step management for primary PPH. Fundal massage is always the first, and they have written IV fluid. They have talked about starting the patient with syntocinon or oxytocin, and then argometrin, and all of these are written one by one. So sometimes after oxytocin or argometrin, if bleeding continues, then specialist will come and then they will try any of the others like misoprostol, intramyometrial prostaglandin, bimanual compression. Then there is B-Lynch suture. Now this is not important for you. It doesn't come in exam. All they want you to know that if you know that if primary PPH is the cause, fundal massage is the first step. That's the first thing that they want to know. Okay. Clear for everyone, primary PPH? Now, secondary postpartum hemorrhage. Secondary postpartum hemorrhage, as I say that from 24 hours after delivery, 6 weeks postpartum, if there is bleeding, that's secondary. The most common cause is poor epithelialization of the placental site. But other cause is, one of the important causes is retained product of placenta and sometimes also endometritis. Endometritis and endometriosis is different. Endometritis is infection of the inner lining, which is the endometrium. And endometriosis is different, as we have discussed in gynae. So endometritis, which is infection of the endometrium, can be another cause of secondary PPH. So that's from JAM. They discussed about secondary PPH, causes, retained product, infection, laceration of the genital tract, and coagulation disorder. So how will you proceed for a patient who has secondary PPH? The first thing is you need to know what's causing it. So you do an ultrasound, you do some blood test, and also if you suspect infection of the endometrium, patient will also have like foul smelly parvaginal discharge. Okay, so when you suspect endometritis is when patient coming to you with a PV bleeding, and they might have a bit of fever, they can have abdominal pain, and they can have a foul smelly vaginal discharge. So then you can think of endometritis. So if you suspect endometritis, then you will also take a vaginal or cervical swab and send it for microscopy culture. So you do an ultrasound to rule out any retained product of placenta. And you do the full blood examination to find out if there is any chance of anemia because of bleeding. You also check for any kind of like sign of infection. You will also start the patient with IV oxytocin and argometrin. You can give misoprostol, even injection of prostaglandin if patient persistently bleeding. Now, depending on what you get, if you get a product of, like a retained product of placenta or conception, then you will need to take the patient to the operation theater and you need to do a gentle blunt curettage to remove the product of conception. If there is no product of conception, and if you suspect there is a possibility of infection, then you need to give them antibiotic, which is 3 antibiotics: amoxicillin, metronidazole, and gentamicin, until you wait for the microscopy culture report. And these are all IV. So IV, amoxicillin, metro, and gentamicin. Okay. So a step-by-step management is what is important for exam. If a patient comes to you with a heavy bleeding and that is secondary PPH, definitely you will resuscitate the patient first. And then you will send the blood, you will do an ultrasound. Okay? And also if patient continuously bleeding, you would start the patient with oxytocin, argometrin, because you need to stop the bleeding first. Okay? So it depends on how much bleeding it is. Secondary PPH are not heavy bleeding most of the time. Okay? So you will have the time to do an ultrasound, get all the tests, and then you can go for all the management accordingly. So if it is retained product of conception, you need to go for curettage. If it is infection, then antibiotic. That's the main treatment. Most common cause is poor epithelialization of the placental site, because placenta get detached from the uterus, and that part will be a bit of bleeding will come out from there. But your body is supposed to like seal that part. If your body is not able to seal that part, that's called poor epithelialization, and that can be a cause of secondary PPH in most of the time. And there is nothing you need to do about it. It will get better. Blood group isoimmunization. Now there is another important thing. So many of you have heard about RH isoimmunization, right? So RH isoimmunization is a condition where pregnant mother who is RH negative giving birth to a RH positive baby. So let's say this is the first time the mother is pregnant. During delivery or during pregnancy time, there might be a feto-maternal blood mix-up. So if blood of mother and the baby get mixed by any way, then what can happen that if RH negative, let's say that somehow there is a mix of blood of the baby and mother. If baby's blood comes into mother's blood, okay, so mother's blood will think this RH positive blood as a foreign particle or a foreign body. So mother blood or mother's body will make an antibody against this. So now after first delivery, the mother has got an antibody against RH positive blood group. Okay. So second time mother gets pregnant, still RH negative, and baby is again RH positive. Now this time mother has an antibody against the baby's blood. So if somehow again there is feto-maternal transfusion, like let's say this time from mother's blood, the blood goes from mother to baby. So what will happen? Mother blood has got antibody against this. So when it goes into baby's blood, it will destroy the baby's blood, and that will cause hemolysis. So that's the main issue with RH isoimmunization. Okay? So it's a very important thing that we would not let this antibody to develop in the mother in the first place. That's the idea. Okay? So how we do it? So we can do it in Australia. Every patient who is RH negative will get a anti-D injection, which is like, so anti-D to the RH negative mother. So every pregnant mother will get a anti-D injection at 28 weeks and at 34 weeks. Okay, everyone. And in that way, you can prevent this antibody to form in the first place. If the antibody does not form, there will be no problem. Not only just prophylactically for 28 and 34 weeks, when there is a risk of fetal-maternal blood transfusion, you would need to give this antibody or this NTD. So after any spontaneous miscarriages, after threatened miscarriages, after delivery of Rh positive baby, following termination or ectopic pregnancy, any other sensitizing event like amniocentesis, chorionic villus sampling, placenta previa, abruption in placenta, okay, any of this time, you need to give NTD to the mother as well. And how much NTD we need to give depends on this Clauhar test. After a sensitizing event, we do this Clauhar test to find out how much fetal-maternal blood has got mixed up and what should be the dose of NTD immunoglobulin. Okay, so that's pretty much about Rh-IC immunization. Next, preterm labor. Preterm labor is if labor pain starts after 20 weeks but before 37 weeks. So preterm means before term. So we know that term is from 37. So if a patient has got labor pain or if the patient has got onset of labor before 37 weeks, that's preterm labor. There are lots of causes of preterm labor, but most of the time there is no cause. So what is the treatment for a preterm labor? The problem is that if the baby is premature, especially less than 34 weeks, the baby will not have enough lung maturity and there is a risk of respiratory distress syndrome. So ideally, if you get a preterm labor, you would at least try to prolong the labor up to 34 weeks if you can. So that's where you get the tocolytic agents. So tocolytics are some medication which can inhibit the uterine contraction. So we have got nifedipine, we have got salbutamol. So any of these can be used to prevent any contraction. If contraction can be inhibited, then most likely you can also prolong the pregnancy. But if preterm labor is like if the labor is inevitable, then definitely you need to go for a steroid if the baby is less than 34 weeks. Okay, so for preterm labor, the only medication that you might need to give is tocolytic agent, no antibiotic. That's where a lot of candidates get it wrong. And Dr. Khan, after abdominal trauma, which is more common, placental abruption is common. And Dr. Mijan, we give 2 times NTD injection at 28 and 34. But what about after birth? After birth also we give it. So Rh negative mother delivering a Rh positive baby, then also you will need to give it after birth. So preterm labor means onset of labor before 37 weeks. What is premature rupture of membrane? Premature rupture of membrane is the labor pain which should start first, followed by rupture of membrane. But if rupture of membrane happens before labor pain starts, that's called premature rupture of membrane. Again, it is the labor pain which should start first, followed by rupture of membrane. But if it happens the other way, like membrane rupture before onset of labor, that's premature rupture of membrane. And if premature rupture of membrane happens before 37 weeks, that's what we call as preterm premature rupture of membrane. So 50% of preterm premature rupture of membrane progress to labor within 24 hours. So the very high risk that it will get into labor. Smoking is a risk factor. Remember, we should not do a parvaginal examination if it is a premature rupture of membrane because you can induce infection, which is chorioamnionitis. So what is the step-by-step management for a patient who has premature rupture of membrane? First thing is you do just a routine examination, including the vital sign. Then you do a speculum examination. In a speculum exam, you would be able to check the cervix. And in the cervix, you can see that there is pooling of liquor in the posterior fornix. If the question says there is pooling of liquor in posterior fornix, that's amniotic fluid. And that means premature rupture of membrane. So you do a speculum exam, and during a speculum exam, you take a vaginal or cervical swab for microscopy and culture. Once swab is taken, then you start prophylactic antibiotic, likely erythromycin, until the culture result is back. Then you need to continuously check the blood for any sign of infection. If no evidence of infection, you can continue the pregnancy. Okay? Until 36 weeks. If by 36 weeks there is no onset of labor, then by 36 weeks you will do induction of labor. So you don't actually reach up to 37 weeks for premature rupture of membrane. So by the time it is 36 weeks, you will go for induction. Okay? So this step-by-step management comes in exam. So first is speculum, take the culture, start the antibiotic, check the blood for any sign of infection, and then based on it, so if infection happens, then immediately patient will need delivery. If there is no sign of infection, then you can continue until 36 weeks, followed by induction of labor. Next, prolonged pregnancy. So we say that term means 37 to 42 weeks. Prolonged pregnancy is if pregnancy is lasting longer than 42 weeks. Okay? So normal delivery is between 37 to 42 weeks. So at 41 week, you'll do a CTG and amniotic fluid index. Amniotic fluid index will give you an idea that if the patient is developing like oligohydramnios, which means lack of amniotic fluid around the baby. If amniotic fluid is good, CTG good, then you will wait for another week to see if normal vaginal delivery happens. But at 42 weeks, still there is no sign of labor, then you start induction at 42 weeks. Induction is best achieved by either prostaglandin gel or vaginal misoprostol followed by artificial rupture of membrane. Okay? There is a risk with prolonging the pregnancy after 42 weeks because increased risk of mortality, increased risk of meconium aspiration syndrome. So premature rupture of membrane, yes, it can cause intrauterine death. That's why you are checking the baby. So if you have seen the JM, so they have written you are going to check the baby very frequently. So continuous observation. If no evidence of infection, continue the pregnancy. CTG every second day or even daily. So if there is CTG gets abnormal, like there is any chance that baby is getting a bit distressed, you would go for delivery. If everything is looking fine, then why would we go for like cesarean section or something like that? You are keeping a continuous eye. Okay. Yes. So mainly, Dr. Sophia, you are right. So prostaglandin E2 gel is usually the way of induction. We don't go for misoprostol. That's right. So intrauterine growth disorders, fundal height greater than the dates. So we were discussing about fundal height greater than the gestational age. The cause of fundal height greater than gestational age is polyhydramnios. That means when there is excessive fluid accumulation around the baby. Could be due to macrosomic baby, multiple pregnancy as well. So if you get something like that, then first thing is that you need to do an ultrasound to confirm that it is polyhydramnios. Rule out diabetes because that's one of the cause. And then you just need to refer the patient to obstetrician. Lots of causes are there which you can read in your own time. Same, oligohydramnios is when there is lack of Leica volume, especially less than 500. There is a risk that baby can get intrauterine growth retardation and the risk of intrauterine death and everything. Investigation is also ultrasound, doing some blood test, and send the patient to a specialist. You can give it a read about IUGR, not very important, but you can read it. Meconium stain Leica. So meconium staining is common after post-term. That means if it is a post-term baby, meconium stain Leica will be one of the complications that we look for. This is also not super important. You can just give it a read. Next, malpresentation. So all of you heard about breech presentation, oblique lie. So all of these things, you need to know about it because this comes in exam. So what is the normal positioning of the baby? So if this is the uterus, the baby is usually head down position, right? And this position is, you can see it is longitudinal lie. And this is cephalic presentation. That means the head presentation. But if it is the other way around, like if the baby is like if the position is like this, the bottom first and head is on the top, that is called breech presentation. There are lots of breech presentation types which you can see here. General rule for breech presentation is C-section because it's very difficult that it will get into a vaginal delivery. But in a very selective patient, vaginal delivery is safe. But that will be only done by an obstetrician. So let's say that you are doing ultrasound at 32 weeks and you found that baby is in breech position. Sometimes baby can change the position. So at 36 weeks, you do another ultrasound. And at 36 weeks, it is still breech. Then there is very less likely that baby will change position to normal cephalic presentation. So at 36 weeks, it is still breech. Then there are two options. One, that you can go for an external cephalic version where the obstetrician can manually change the position of the baby. There is a small risk of hemorrhage. So that's why it is always done in a setting where emergency C-section is possible. If ECV or external cephalic version is unsuccessful, then you will go for an elective C-section at 38 to 39 weeks. Okay, so that's management for breech presentation. Then there is transverse or oblique lie. So we know that the baby's lie or the position should be like this. So the longitudinal lie is the normal lie. But if baby is staying obliquely or transverse like this, that's what we call as transverse or oblique lie. So these presentations are not normal. And you can understand that like there is no possibility that it will go for a normal vaginal delivery. So there is a high risk of obstruction, like obstructed labor, if the mother goes into labor. So normally by 36 weeks, again you will check that if the lie got normal by itself, by 36 weeks it is still not changed. So you say that should it persist beyond 37 weeks, admit to the hospital, and cesarean section is the best option. So you can do another scan at 36 or 37 weeks, but by 37 weeks it hasn't changed the position, you will go for elective cesarean section. Cord prolapse or cord presentation. Sometimes you can find out, especially for transverse lie patient, the cord can get prolapsed parvaginally. So when you see that cord has got prolapsed, the first thing you do is examine the cord and try to feel that if it is still pulsating. If cord is still pulsating, you will push the presenting part away. So let's say this is the presenting part and this is the cord. You will push the presenting part away from the cord so that it doesn't compress the cord. Because if you compress the cord, the baby will not get blood supply. So idea is if you can feel the cord pulsating, you will push the presenting part away from the cord, and you will need to do it manually by your hand. You will keep your hand there by continuous digital pressure. Okay? And while your finger or your hand is there, you will take the patient to the emergency theater and go for a cesarean section while maintaining the position of the hand. Okay? So that's cord prolapse or cord presentation. Comes in exam. Okay, we'll finish it here tonight. Malposition is not important, but remember there are like commonest malposition is occipital posterior, and for most of them we go for cesarean section, but it doesn't come in exam anyway. So we'll finish it here today. There is still a lot to finish. So in obstetrics, we always struggle to finish in 2 classes, but we can't even extend the class for more than 2. So the main thing that you guys also need to go through is infection during pregnancy. That's a very important chapter. That will be our first topic that we will discuss next class. And then we will start with the early pregnancy bleeding and other things. Okay? So if cord prolapse happens, Dr. Mimona, you will push the presenting part away from the cord. You'll keep your hand over there, like you will push it, take the patient to the operation theater and go for a C-section. We are not putting the cord manually inside. We are actually just pressing we are making sure that the cord and the presenting part is not getting attached, or we are making sure that the presenting part is away from the cord. It's not about pushing them inside. It's about making sure that the cord is not getting compressed. And Dr. Khushbu, yes, shall we read theory note for today's class? Definitely. Theory notes is important. That's from where we are discussing most of the topics. Any question, guys, from today's session? Now, if baby is negative and mother positive, there is no way there will be any problem. It only happens in Rh negative mother. Membrane sweeping doesn't come in exam, as far I know. And Dr. Fatima, all our mentors are discussing the monthly questions, right? So that's how you get it. And there are also groups. So there are lots of groups available, but for our group, there is a Telegram group where you can get added. But we discuss the question solve in our class. So if you are new, then you would see that lots of question solve classes are happening. So that's when we discuss the monthly questions. Okay. But there is a Telegram group for our course. You can see the Telegram group link in the featured section of the Facebook group. And if that link is not working, just let me know. I will open a new link. So in premature rupture of membrane, Dr. Nancy, it's mainly about, not about just the liquor, it's mainly about how the baby is doing. So as long as baby is not in distress, we will continue the pregnancy. No, yes, you can go for induction in preeclampsia also, Dr. Eva, not always C-section. No, if it is IUFD, Dr. Mitra, you don't go for C-section. You go for induction. Because C-section is a surgery, and there is no point of going for surgery when baby is already dead. You go for cesarean section in abruptio placenta when the baby is really unstable and you can still save the baby. Okay, all good, everyone. Have a good night. Please try to finish what we have discussed today. It is a lot, but again, you can see that we are not going too much in detail, and that is not needed also. You just need to know the basic. As long as you know the basic and the main part, you are good. Okay? Thanks, everyone. Have a good night.